ইসলাম স্যার ভালো আছেন?
স্যার আসসালামু আলাইকুম স্যার, আমরা
Um,
এখন শুরু করতে পারি।
Thank you very much. Hello and welcome everyone. I'm very delighted to welcome you all. We are very lucky and delighted that we have got very learned faculties, both from here in UK and also all the very learned and uh, eminent figures and professors in urology from Bangladesh. We have Professor Abdul Salam. He kindly volunteered to present today. Our topic today would be some kind of, it is a little bit debatable, the talk, which is kind of comparison between open and a robotic radical cystectomy. And I believe Professor Salam has a wealth of experience in cystectomy in Bangladesh, who is a kind of pioneer about this operation. So we'll be very delighted and it will be a resourceful discussion, I hope. And we are really looking forward to share the knowledge across the globe. May I request Professor Salam sir, please if you can start your presentation.
Okay, so Assalamu alaikum. Sorry for the delayed joining. I had an issue with internet. Assalamu alaikum. Sorry, I had a bit of an internet issue. Yeah, okay. Thank you for joining, everybody. Thank you.
Thank you, thank you. So I have been asked to proceed to the presentation, but before I go to my presentation, I would like to tell you that it was very interesting to me. This topic is a topic. One part of the topic is blind to me. For example, robotic cystectomy and open cystectomy. We do a lot of open cystectomy. Our center is a high volume center, no doubt in that. But I am not exposed to robotic system. I am very glad that I have got now quite a number of participants who are very much proficient in robotic urological procedures, including cystectomy. And you may be very delighted to understand that the robot has stepped in at least in two places of Dhaka city. One in Square Hospital, another is in United Hospital. So we are not completely blind. At least we will be able to see, we'll be able to understand from our colleagues, those who are using it. So without any delay, is it a presentation? You can see? No.
Not yet.
Not yet, yes. Where to go? Just a minute. Please allow me a few minutes. Now? No.
নিচের শেয়ার বাটনটা দেন স্যার।
শেয়ার বাটনটাই তো দেখছি না।
একদম নিচের দিকে, নিচের মধ্যে দেখেন স্যার, একটা আছে সাদা অ্যারো করে দেওয়া।
দেখছি।
পার্টিসিপেন্টের পাশে দেখেন স্যার, পার্টিসিপেন্টস এর
ব্লু
পাশে।
বাটনটা, তাই না?
হ্যাঁ,
শেয়ারটা না?
হ্যাঁ, শেড। এই তো
এবার হয়েছে না?
এক্সেলেন্ট। হ্যাঁ, এখন দেখতে পাচ্ছি।
I am so happy. So this was a great debate. And this debate is whether over or not, that is a question. So highly equipped center with Da Vinci robotic system or other system like there are robots from other countries as well, other origin as well nowadays. So, and the traditional surgery or the surgical team is represented by this ant. So this seems to be a fight between the ant and an elephant. Let us see what has happened over the time. Evolution of the Da Vinci robotics.
Full screen দেন স্যার তার আরো ভালো দেয়
Right. Good idea. Is that correct?
Yeah.
I hope so. Da Vinci robotic system was introduced in 1999. In 2006, they have got some improvement. In 2009, 2009, some improvement. Da Vinci Xi came in 2014, and in 2017, they have got the Da Vinci X, and they have got Da Vinci Xi. Sorry. XI, the single port robotics surgical instrument. So all these development actually made the task very much easier for the surgeon. If someone is skilled, then the task become very precise, very nice, and very comfortable for the patient. Now the question is, when we have decided to do a radical cystectomy on a patient with MIBC, means muscle invasive bladder cancer, then certainly we would have to think about which one should be the best. Should I send the patient? Many patients are caring nothing. They are going abroad for having a robotic surgery. So here comes the debate. The robotic surgery is better or open surgery is better. Robotic and laparoscopy, I consider both are same. So how the debate evolved is something like that. Era 1, the previous era, open radical cystectomy was considered to be gold standard. Era 2, the introduction of the laparoscopy or robotic assisted radical cystectomy. And then era 3, focus on the outcome, not the incision size. Possibly we are in the era 3. Introduction of laparoscopy and robotic surgery was a revolutionary approach, and that make everybody very happy and enthusiastic to have this technology. But soon the people understand, those who are connected deeply with this technology, they could find that their complications are also not less. Their hospital admission, readmission was also not less. Their side effects are also not less. And they started to think about whether the open surgery and this Da Vinci robotics surgical procedure are having the similar outcome. Even the oncological outcome, is it same? So there was quite a number of study. We will go to that. Why this debate matters? It is really matters. Radical cystectomy is a high risk, high impact surgery. The choice of this approach influences the complication, cost, training resources allocation, and the surgeons and patients still ask which one is better. This actually people are perplexed. The intelligent patient are also perplexed. But most of the patient, they rush on the new development, new equipment, new services without thinking anything. I can remember one historical issue. President Clinton went to the Cleveland Clinic. He said that I need to have a coronary bypass surgery. Will you be able to do that? Then the senior cardiologist said, yes, we can do it with robotic surgery. Then President Clinton just tipped his hand and said that no new technology. The technology which is conversant and very confident you are, I want that technology. He was operated there. So which one is still better? Many surgeons and patients still ask which one is better. The debate has come to an end. Why come to an end? Because there are two robust study which was made to answer this question. We'll come to that very soon. The debate regarding the robotic cystectomy versus the traditional radical cystectomy, open radical cystectomy, has largely been unified. And today, both are oncologically sound and safe. Oncological outcome and perioperative benefits. The oncological outcomes are there is no single significant difference on progression-free survival, overall survival, or positive margins between the two methods. The perioperative benefits, robotic surgery consistently shows the significant lower estimated blood loss. That is an advantage. And lower the blood transfusion. It also associated with shorter length of hospital stay. These are the best benefit which can be achieved with the robotic surgical procedure. But definitely with the open radical cystectomy, we are going to see the more blood loss, more blood transfusion, and length of the hospital stay a bit longer. The time taken for the radical cystectomy with the open radical procedure is shorter, but in robotic surgery, it may be little prolonged. But with time, one can be very fast or even faster than the open surgical procedure. I have quite a number of people who are very confident in the laparoscopic surgery. I have seen the cystectomy, 3-window technique. They are doing it in their own institution. I can name our junior friends, colleague, once upon a student, but they became our very affectionate colleague. They are doing the radical cystectomy in their institution smartly. I'm very proud. I'm sure that when the robotic system will be handed over to them, I'm sure that they will do miracles. Next, the complications of the radical cystectomy and the urinary diversion or orthotopic bladder is a complex procedure. The radical cystectomy is a high-risk operation, and historical rate of open approach of complication is 30 to 60% even, and mortality is about 3%. These are the honest reproduction. What I think, in our center, we don't see so much complication. I'm sure they are not so much, but if we become very honest, I'm sure that we'll be able to remember and noted lots of small and minor complication which is ignored by our habit is also to be noted. So if we do that, the complication rate will be around 30% to 60%, and mortality is 3%. So the complication and readmission and mortality, if we recognize it is with the radical cystectomy, robot-assisted radical cystectomy, early, late, and overall, 90 days complication is about 27%. Mortality is 7%, or overall, 90 days. But in early, it's about 2%, in late about 5%, and readmission rate is about 20% in early, late about 11%, and overall 27%. Open versus radical cystectomy. There is no difference in readmission. 935 patients, 785 open and 150 robotic, that is about 84 versus 16%. The length of stay was short in robotic surgery, and there is no difference in 30-day admission rates and no difference in the length of stay in readmission or reason for readmission or time in readmission. Defining two approaches. The open radical cystectomy established technique. This is as old as very long, widely available. Proven long-term data is available. The minimally invasive surgery or robot-assisted radical cystectomy produces excess trauma, reduces the excess trauma, technology dependent, and the surgeon's experience is very sensitive issue. Oncological outcome, the surgical margin, the lymph node yield, lymphadenectomy. Dr. Fazal Nasser did lymphadenectomy very nicely, and I'm quite proud of him. Not only the lymphadenectomy, he does most of the work really better than many people's. Surgical margins are a very important issue in open operation as well as in robotic surgery. The progression-free survival, they are also similar. Cancer-specific survival, evidence shows that the oncological equivalence when they are performed well. The most important point is if it is performed well, only then it is good. If it is, the technology is not important. So the people behind, or the man behind, or the hands behind, the skill behind the machine is more important. So this particular fact was underestimated. Previously, robotic surgery is better because it has got a shorter hospital stay, small incision, and so on, etc. But evidence has shown that the oncological equivalence, when it is performed well, will be better. Anyone. Key randomized trials. These two key randomized trials actually made the thought process in the line which I am describing to you. The Razor trial. The robotic assisted radical cystectomy is non-inferior to open radical cystectomy. There's a very bold and very sincere appeal or the comment. MSKCC experience no reduction in the overall complication by robotic system, using the robotic system. The message is quality surgery matters more than the approach. So not the machine, but it is the person who is doing it. Complication rate. Overall complication rates are similar. Major Cleveland 3 is similar. Difference lies in time, but not in number of the complication. This is true. Perioperative differences. The robotic assisted radical cystectomy, less blood loss, fewer transfusion, longer operative time. It can be comparable to this electric versus manual toothbrush. Electric toothbrush has got certain facilities, but again, if you take the toothbrush, which is manual, it may not have such kind of sophisticated alarms, such kind of strokes, 1,000 stroke per minute. It may not be like that, but it cannot be ignored. It is very simple, very easy, and can user friendly. The cost is, of course, it is a lower cost. Easier and reproducibility is a very important quality of open radical cystectomy. But unfortunately, the more blood loss is seen, hospital stay is longer, and but the shorter operating time. Robotic cystectomy may take a little longer time, but consumes less blood. Urinary diversion, extracorporeal urinary diversion limits the robotic assisted radical cystectomy advantage. Advantage means it become faster, but intracorporeal diversion is less bowel handling, potential reduction of ileus, and wound issues. That technically this is demanding, but it has got a steep learning curve. At this particular point, I would like to address that the cystectomy patient, they get up quickly when the peritoneum is completely closed. The procedure is much better tolerated. The bowel sound or the bowel function recovers much earlier. But if we cannot close the peritoneum, in those cases, the bowel function returns late. And particularly if you use a ERA system, the epidural catheter is used for epidural infusion or that intermittent injection of analgesics. They are used for analgesia. And many times we have seen that the overdoses makes little problem. 2-3 complication that comes. One is the patient become immobile. So chances of bed sore is very important. So a pneumatic bed is very much important. Then the pneumostatic, the pneumonia or orthostatic pneumonia. Maybe that requires little attention unless the drainage system of the pulmonary system is carefully monitored. There may be a possibilities of pneumonia. And again, the bowel function returns back little late. Those are the issues of I'm sorry, we were discussing about the patient management with anybody help me?
I think we're talking about paralytic ileus and wound.
Paralytic ileus following the
open versus robotic. It's worse in terms of open, right? And you were saying mostly about the peritoneum having to be closed to get an earlier
yes,
reduction.
I was talking about more emphasis on the rehabilitations. I skip this particular point. I will try to explain later. The Razor trial that we have discussed before. The purpose of the Razor randomized open or versus robotic cystectomy. A study to compare open radical cystectomy versus robot-assisted radical cystectomy, pelvic lymph node dissection, and urinary diversion or oncological outcome, the complications and the health-related quality, HRQL, and measure of the primary endpoint, 2-year progression-free survival. So it was a multi-institutional, randomized, non-inferior trial which enrolled at least 320 patients, T1 to T4 and 0 to N1, the bladder cancer with 160 patients in both the radical approach or the open radical cystectomy arms. 15 participating institutions. Those 15 institutions are Mayo Clinic, Arizona, Stanford University, the University of Texas, the University of Michigan, University of North Carolina, the Mayo Clinic, Minnesota, the University of Minnesota, the University of Chicago, University of Virginia, the University of Miami, the Ohio State University, the Vanderbilt University, the University of California, the Loyola University, the Brigham Women's Hospital, and total 306. Even by contributing one hospital, Brigham Women's Hospital was included. So it was a very authentic study because so many prestigious institutions was involved in this study. The conclusion of the study was the RESOR study is a landmark institutional, multi-institutional prospective inferiority trial. Non-inferiority trial. Evaluating the oncological outcomes, surgical complication, HRQL measures of open radical cystectomy or robotic assisted radical cystectomy in patient with T1 to T4, N0 to N1, and M0 bladder cancer with primary endpoint for 2-year PFS, progression-free survival. Thus, part 306 patients have been randomized to RESOR study from 19th August 2011 to 19 December 2013. An average of 11 patients occurred per month with the expected completion of patient accrual in 2014. The full data of the RESOR trial was not anticipated until 2016 to 2017, but should be provided much needed in one data about the comparative efficiency of
efficacy.
robot-assisted radical cystectomy or open radical cystectomy in terms of both cancer control and HRQL. So next to the study of RESOR study, the Sloan Kettering Memorial Hospital experiences have shown that while the cancer-specific outcome have improved, there are no significant reduction of overall 90-day complication rate when comparing with the robot-assisted radical cystectomy to open radical cystectomy. So this is very interesting. Both the study actually saying the same thing. Memorial Sloan Kettering Center also saying that no difference in complication, high initial morbidity, common complications, improvement in other areas, and quality of life are also similar. Learning curve and surgeon volume. The robotic assisted radical cystectomy outcome improves after 30 to 50 cases. So this is quite important to understand that the cases which are early cases is likely to have more side effect, more complications, and although maybe the recovery will be late. The early learning phase is associated with higher complications. The high volume centers show better result regardless of the approach. The third point is very important. High volume centers show better results regardless of approach. The cost and resource consideration. The robotic systems are very expensive. The maintenance and consumables are added cost. Open radical cystectomy remains more feasible in the low and middle income setting, from 3 to 5 lakhs of Bangladeshi BDT, inclusive of all. Robotic assisted cystectomy, often ranging from about 15,000 US dollar over 20,000 US dollar, driven by the higher operating room. These are fixed costs. While the robotic approaches can have higher instrument fees, $1,000 per case, and longer operating time, they result in lower blood loss and hospital stay compared to open. So all these things makes the robotic system still more expensive. But I'm sure that with time, when this will be available everywhere, the cost will come down. That has happened in the US and in other countries as well. In our country, that will also happen. Is the debate really over? What is settled? The oncological equivalence, that is settled. What is not settled? It is the cost effectiveness. It is not this debate is not over. Universal availability. It is also not over. This machine is very expensive and not available everywhere. Learning curve has got a big impact. It will take a long time to be conversant with each and every steps of the procedure. So debate is truly not over. The modern perspective or the key message is radical cystectomy is not defined by the incision, but by the system delivering it. What is the system which is delivering? Maybe the robotic or maybe the open radical prostatectomy system. The surgeon, the team, the volume, the protocols. The ERAS protocol, I forgot to remember this name. I'm 75 in the last 24th January. So I started to I'm sorry about it. So you see, this is a very simple example. Even the end, which is an open surgical technique, can beat the big surgical establishment with robotic system if they are not very competent. So competence is more important thing. So anything which if you'd like to take from this presentation is the competence, and the high volume. So we'd have to do more and more cases, and more effectively, more usefully, and without any mistake. While I was working in the university hospital, I always tell that your mistake in one stitch in radical cystectomy and urinary diversion procedure will kill the patient. It happens. So the take-home message is the debate is no longer logical. Both the approaches are valid in experienced hand. The patient selection and the surgeon expertise prevents complication. The best operation is that which is done best. I think we have come to an end, but it is very important to see the last few slides. Neoadjuvant chemotherapy, classical open radical cystectomy, urinary diversion, or orthotopic bladder is one of the best choice for treating the MIBC. Neoadjuvant chemotherapy, the robotic radical cystectomy, urinary diversion, or orthotopic bladder standard. The neoadjuvant chemotherapy plus cisplatin plus gemcitabine plus nivolumab plus minus cystectomy is also a good treatment. The next slide, I am very much impressed with the slide, which has come from the information came from the Sloan Kettering Memorial Center and Columbia Hospital. They have recruited 76 patients. I'm going later, but the important message here is there is no role of radical cystectomy in CT0 after the neoadjuvant chemotherapy. So these patients may have a cystectomy-free survival in 76% of the MSKCC. What they done, 76 patients, they were treated by the gemcitabine, cisplatin, nivolumab, 4 cycles. 64 patients actually completed the study. 31 patients, they had clinical response, but 33 patients did not respond. So they offered the cystectomy, radical cystectomy, whatever may be the procedure. The patient who responded, 30 patients, no cystectomy was done. Nivo 4 months. Nivo means nivolumab. And the clinical and the other one patient who underwent a cystectomy because eventually he didn't improve. So half of the patient, they remain trouble-free or cystectomy-free life. That is a great achievement. So if the medical treatment become improved or the futuristic treatment with robotic compound with AI, if improves, then possibly this radical cystectomy, which is considered to be one of the very, very mutilating operation for the muscle invasive bladder cancer, will be an end. So having said that, I would like to thank you very much for the very kind attention. Thank you very much. If there is a question, then we can discuss.
Thank you, sir, for this very resourceful talk. And at this point, I'd like to introduce 2 of our learned faculty, particularly for this meeting. Is one of the very senior urologist and quite experienced in this regard, Ms. Jumur Pati. She's consultant urologist, I believe, in Homerton University Hospital.
Didi, namaskar.
And namaskar, কেমন আছেন? Salam, sir. It was a lovely talk. Excellent talk. Excellent talk. Thank you so much.
প্রভাত যদি সম্ভব হয় দিদিকে আমাদের কাছে নিয়ে আসবেন। দিদি কিন্তু আমাদের দেশের মানুষ। এই যে রণদা প্রসাদ বাবু ছিলেন ইয়েতে, যিনি ক্যান্সারের ট্রিটমেন্টটা সেই 1960 সালের দিকে উনি অ্যাভেলেবল করেছেন টাঙ্গাইলে, তারই নাতনি।
Thank you very much, sir.
She doesn't require any introduction, কিন্তু আমার মনে হয় বাউসির মিটিং এ যদি আসতে পারেন আপনি তাহলে খুব ভালো হবে। না হলে কোনো এক সময় আমাদের একটা ইনস্টিটিউশন আছে, সেটা হলো ইউটিএফবি। সেখানেও আমরা অঙ্কোলজিতে কনফারেন্স গুলো করি। আমরা ইনভাইট করলে আপনি দয়া করে হ্যাঁ বলবেন, আমরা যথেষ্ট আগেই আপনাকে জানাবো যাতে আপনি আসতে পারেন।
No, thank you so much, sir. So, Apna talked presentation was excellent. Thank you for picking a topic which is very close to our hearts. You're right, it's a very mutilating operation. And the patients usually, definitely in England and America, they all have neoadjuvant therapy if possible. I'm sure in Bangladesh also, the preference is that if the patient can have it.
We do not operate without a neoadjuvant chemotherapy 6 cycles.
So এইখানে জিনিসটা হলো যে already the patient is quite traumatized with the chemotherapy. Chemotherapy has significant side effects for patients.
Absolutely.
And then to be put through surgery is a second line of trauma for the patient. So whatever can be done to minimize this, and as you say, it's not really about the instrument, it is about the man behind the instrument and his team. You can use enhanced recovery protocols in all different types of surgery. We are very onto it now. And in cystectomy, we use, apart from epidurals, we're also using opioid-free tap blocks. So, so these all help for enhanced recovery. But if the incision can be smaller, I mean, I recently, my husband has gone through surgery and he was up after major surgery, he was up the next day. So because it was robotic. So I am slowly getting converted into these more minimal, but as you say, the most important thing is the person behind the machine. The other thing which is more perplexing for me is when to ask the patient to have a cystectomy, not so much in muscle invasive disease, but also in superficial high risk disease. Superficial high risk disease is one of the worst diseases, in my opinion, for bladder cancer.
Of course, yes.
Because it is because it's the word superficial gives you the false hope that this is not going to be dangerous. But within that superficial high risk category, you have very, very serious histopathological variants.
Non-muscle invasive bladder cancer, which are refractory to BCG or other agents, should be submitted for radical cystectomy.
Yeah, well, even in my opinion, even if these subtypes are already identified, for example, sarcomatoid, squamous cell differentiation, plasmacytoid variant, spindle cell, these are very dangerous, even in the superficial component, and we may be understaging the disease. So we are understaging the disease and we are giving the patient perhaps the wrong treatment if we are giving them BCG first. They should not even go for BCG. They should directly be offered cystectomy. So I think as our technique gets better in doing more minimally invasive techniques, but also trying to give patients a neobladder wherever possible, that will help help the patient to make a decision.
Your wording is very close to my heart.
আরেকটা জিনিস যেটা খুবই ইম্পর্টেন্ট সেটা হচ্ছে যে the the neoadjuvant setting এ এখন অনেক সুন্দর সুন্দর ড্রাগস বেরিয়েছে আমি সুন্দর সুন্দর বলছি because they are giving us hope. There is a new drug or regime called EVP, enfortumab with pembrolizumab. This regime is now currently being used for inoperable cases. And we are hoping to see that these inoperable cases you have to say that the patient is inoperable before they are allowed to go on this trial. And these are usually T4 disease with, lymph nodes, etc., sometimes stuck to the pelvic sidewall. We are looking at those particular cases and we are finding that some of those cases are actually becoming operable. So this is another setting in which case, we may find that history is changing for these patients. And the patients will then be able to have surgery even when they were deemed inoperable before. I'm going to stop because I think Shafi has a question.
Okay, thank you for the contribution. But also before I go to the questions in chat box, may I also ask another faculty, Saiful Mia is one of the robotic surgeons here in Cambridge University Hospital. He might have some opinion because he is a practicing robotic surgeon.
We are very keen to hear from you.
And Kausar, can I just say that I'm very grateful to all the professors, the panel, for joining our meeting today. It's really very highly, appreciated for giving your time. Thank you so much. Moving on to Saiful. Welcome, Saiful.
Yes, welcome. Thank you, Professor. Fantastic talk as usual. I'm working in Cambridge, and I always say with cystectomy, it's the main thing is a person behind and doing the operation, not the tool. In Cambridge, we're lucky enough; it's mainly a female-led surgical team that performs a radical cystectomy. 2/3 of our pelvic surgeons are female in Cambridge, and it's like I said, it's the people behind the operation, not the tools they use. If I wanted a cystectomy, the first thing is, the surgeon experience, the assisting experience. I always say robotic surgery, you're very reliant on your assistants and how well they can assist you in the surgery, because a lot of the times using someone who's not particularly used to that surgical tool can make your operative pathway very stressful in nature. And like I said, I fully agree. There's no inferiority. The studies have shown that, but it is getting more and more adopted as time moves on. So I think the learning curve for a robotic cystectomy is getting quicker than it was before, and that will be with all robotic operations. But fully agree. At the moment, there's no oncological benefit. I think the costings are much more than we think, because the service commitment for a robot is more expensive. The actual tool, the instruments, it's a very expensive tool, but I'm hoping they come cheaper. And in terms of complications, I've worked in I think 4 different high volume centers. It's a highly comorbid operation. I don't know any center that's got a low complication rate, and I'll even say that in my home center, it's a very, very tough operation, and the hard part of the operation starts when you put the final stitch in. But no, thank you for a wonderful talk, very insightful.
Okay, thank you, Saiful. So I'll take some question from the chat box, although we have limited time. So I think the first question was from Colonel, maybe Brigadier Shafi. He is asking about when we call it a high volume center. I think is about surgeons number. Either Saiful or Ms. Jumurpati, I don't know how we define high volume center in this country.
I think I can volunteer.
Yeah, yes, sir.
About 20 patients a year. 20 patients a year should have radical cystectomy in a single center by the same team.
Yeah, okay. Agree with it with this?
But something like that.
Sir, may I add, sir?
Yes, please.
Sir, it's defined by 2 things. It's the hospital volume and surgeon volume. So if it is a hospital volume, it should be in between 20 to 30. But if you consider a surgeon, it should be more than 10 by him, same surgeon and same team.
Right.
Okay,
Thank you.
Then another question was the lymph node density in radical cystectomy. Is it about how many lymph nodes is taken in lymph node dissection? I think.
It's also about the level at which the lymph nodes go up to. Yeah. So we try to aim to go to at least the bifurcation of the iliacs. So just above the level of the bifurcation. And in some very tiny number of cases, you can go into the para-aortic as well, but definitely you want to take all the pelvic nodes, including obturator, right up to the bifurcation.
And also the sacral lymph nodes.
Yeah.
And number should be about 20, 22.
20, yeah.
Sir, absolutely correct, sir. It depends upon the extension, whether it's standard, extended, or the super extended. So in case
super
of the standard,
they go they go to the
inferior mesenteric
artery.
Yeah.
Yeah. Okay. Is there any certain number?
Other important.
I think.
Okay. Yeah, there are certain numbers also. In standard, we took 15 to 20s, and extended 35 to 40, and super extended more than 45 lymph nodes are taken. and each one should be examined.
Okay. Thank you. I
There
think
are
that
other opinion which is also existing in the market. That is, the lymphadenectomy, if it is avoided, nothing great harm is done. And morbidity of the lymphadenectomy is added to the recovery. It became delayed, and sometimes the lymphatic accumulation like lymphocyte and other things actually interferes the recovery.
okay.
And again,
But in
there
the
are an opinion that only few lymph nodes to judge whether it is extra organic. Extra organic means it is beyond the organ. That is limited lymphadenectomy of the pelvic lymph nodes is good enough. So I'm sure that there is no great consensus about that.
now in the era of
Hello.
neoadjuvant chemotherapy, I mean, what actually should not limit the actually action because of the morbidity? Is there any comment from the panelist?
Okay, so shall I take one more? So I think this can be interesting. So I don't know if we know about any evidence if incontinence or an erectile dysfunction has got different rates in open versus radical cystectomy. Incontinence means, although there are urinary diversion, so we may not comment about incontinence. However, if someone has got orthotopic bladder, in that case, regarding the control or erectile dysfunction, does it vary between the techniques? Any idea or any evidence?
No, that's a very good question, isn't it, Professor
That
Salam? I
is a
think we
very
talked
good
about
question.
sexual rehabilitation, didn't we?
We had some discussion in the previous meeting.
Yeah.
Interesting enough that the robotic surgeon will perform better to isolate the nerves and do this part of the work more efficiently than the open surgeon.
Yeah, and prostate capsule sparing, because that helps with preservation of the nerves as well.
And also preservation of sphincter maybe, because if we are doing robotically, then more precisely you can save the sphincter.
Yeah, I mean, that's important if the patient is having a new orthotopic bladder.
New bladder, yeah.
Yeah, but not obviously for ileal conduit, it doesn't matter.
Radical
Jumrapa, in your
cystectomy,
series,
there's no
what's the
difference.
percentage? Do you know
For erectile
erectile
dysfunction, so
dysfunction?
I used to do only open.
Yeah.
And I would say, you remember, these patients are plus 75 most of the time.
Yeah.
Younger patients, I would say probably about 50% would become, unable to have sex after, no erections after. But in
You
those
say
who
the
were
positive
already okay,
50% will be potent, and another
yeah,
rest of them will
but
not be
in
able
those
to.
patients only who were potent pre-op. I mean, many of these patients would be not impotent pre-op already. So, and their concern was not so much that. The other thing that I'd just like to throw a little bit of light on is female cystectomy. And I feel that female cystectomy was, the sexual function side of things was not really addressed properly
Absolutely not
in
addressed.
years before. And
Yeah.
I'm very happy to hear that there are more female surgeons now, and I'm sure we've done several studies now which are going to focus on outcomes for female patients who are undergoing cystectomy.
Rather, in female patient, we are more aggressive to remove the entire
Vagina.
Yes. Not only vagina, even the reproductive organ, all reproductive organ taken as a en masse.
Yeah, it's mostly about the length of the vagina, though. Reproduction they're usually above 50, so they've gone through menopause, but it's the length of the vagina that's left behind that is going to dictate their sexual function afterwards. And so that is an important thing to try and preserve if possible. So yeah, but more light is being thrown on this now as there are more female patients and female surgeons.
Yeah, I can echo that. For radical prostatectomy, I don't even say 50% recovery, 33 at best. I mean, unless you got high pre-op function, I don't even discuss it. You know, I always say, even if I did the operation on an 18-year-old, it'd be 50-50. You know, most of my patients for prostatectomy are 65, 70 plus. So I'm quite honest with them, saying 30% chance of getting it, because if you already got harbor any dysfunction, you're not going to make it better.
Quite interesting.
Okay. So I think it was very nice participation. I do not see any further questions in the chat box.
Okay.
In that
So,
case,
so Kausar, I just want to raise a thing. Is first of all, as the lead faculty, thank you, Kausar, for being a fantastic moderator. Professor Salam, as usual, you're a fantastic speaker. We always welcome your presentations. So our next date will be the 21st of June, which is a Sunday, if you can keep in your diaries. This time I am looking for volunteers. I think Professor Salam quite rightly has raised some, we discussed a few topics previously, haven't we? Talking about active surveillance in prostate cancer, PSMA PET scan, then muscle-invasive bladder cancer. If we're talking about G3PT, PT1s and PTAs, if you're giving them BCG, what next? I think there are quite a few topics that we want to discuss. And I'd love to have some volunteers to present at the next meeting, if you can. Prabhada, I can see your hand up. You want to add something?
Thank you, Dr. Shafi. I express my gratitude to Professor Salam. It's a nice presentation, and it's a very clear message about the talk. And already I congratulate all the participants, and particularly those who discussed the different questions and answers. My one comment I'd like to say here, that several RCTs trial in the different years, particularly after 2010, 11, 13, and already Professor Salam sir mentioned in his presentation. And actually, there is no significant difference between irrespective of operative time, the blood loss, even the narcotics requirement, the bowel function, and so many, irrespective of so many variables. Even then, recurrence rate, cancer-specific survival, overall survival. But my question is that the world is moving towards the RARC rather than open. But one interesting study in 2002 to 2012 is under the surveillance epidemiology and end result program shared data. So one of the researchers, Hugh et al., in his study showed that after 30 days follow-up, the median cost regarding the RARC and the open ORC is almost similar, about 24,000 US dollar, respective of 21,000 US dollar. How it could be? It's a very interesting findings. I like to.
If you send me to America, I'll be the most expensive surgeon. Do you understand my point? In America, most of the surgeons are surgeons with robot, means all are robotic surgeons. There are very few open surgeons they are working. So they have enhanced their...
This is the scenario of the developed countries, but like us, the developing countries, if we like to switch from open to robot, there is you mentioned it's a huge learning curve. It's a very high learning curve. So in between the laparoscopy is there.
Cases.
So how we could minimize that cost?
Very difficult. In that case, you would have to increase the case. উস্তাদের হাতে ধরে যদি শিখতে চান তাহলে
that means what discussed previously, the center volume.
আমি এটা বুঝি নাই।
Sir, high volume.
High volume.
High volume what explained by Professor Fajal?
Prabhat,
high volume centers.
last year in my unit in NICDO, I did 24 radical cystectomy, all well laparoscopically. And in my private, it was only 4. And among the 24, 2 patients were only female and 22 were male. So when I switched to radical cystectomy in 2016, it took near about 6 hours time. Now I can perform within 3.5 hours. So it definitely is a steep learning curve. The time is become less and less. And one good thing is that the morbidity. So it's very less morbid patient. And the next day when I visit the patient in the post-op, is very fantastic. There is no midline incision mark. It's less pain. And I think for the developing countries, still laparoscopy is a good options. So when I was in UK, I saw in Castle Hill Hospital, which is also a high volume center, they got robot at the time, but they used to perform the open surgeries because the cost is a good concern, very big concern. In laparoscopy, the involvement of the resources are less than the robot. So robot should be
absolutely correct.
Yeah. For my country, the era of robot is just beginning. There will be more robots, more companies will be there. They will provide low cost robot. Then we can switch. Otherwise, we should be concentrated on the open and the laparoscopic radical cystectomy and diversion.
And the other thing, Fazal, you have to remember that the Chinese robots are coming out, which are much, much cheaper from the Da Vinci's. Yeah.
Cheaper,
so
but not the cheapest. Still, it's around 13 crore.
Yeah.
And the maintenance cost is also high.
And maintenance cost is around 50 lakhs per year.
Can I just volunteer simple data? Worldwide, still 15 million surgeries are being done with the robotic surgery, and 300 million surgeries are being done with the open techniques and laparoscopic one. So basically,
the whole world. Yes. Most of the people.
The whole world is 15 million only. Is the data from 24. So we should not be considering the Arabs and the Western countries, the whole world. The world is very big. Africa is in Asia, part of the things. Most of the people is still under the minimum standard of living, so they can't really afford that. So it must be. I totally agree with the puzzle that we should be learning towards the laparoscopy still, because maintaining of the robot is very much costly.
So Professor Salam, can I make a request for next time? I mean, we've done quite a few of us have done a few presentations so far over the years. Is it possible that one of the Bangladeshi trainees can kindly do a presentation for us? I think it's good for training purpose and, for a platform like this. I think it will be very good, isn't it? Yeah, if we can select a topic and let me know. So if you can WhatsApp me one volunteer. Yeah, I would like to. I like to encourage our trainees as well, the urology trainees, to come forward. We have had urology from UK. It'll be very good.
Number of people.
Yeah, it improves their presentation technique for a world stage platform. At the same time, it gives insight to everyone. I think it will be good for us.
Prabhat can help us.
So Prabhata as well, if you can kindly see if we can do something. If
I think it's an excellent proposal. Excellent proposal. So I can send a message to our trainees and the young urologists.
Thank you so much.
Prepare
Thank you.
For the next month.
Yeah, so it's 21st of June, Sunday, same time, 10 p.m. for Bangladesh. And I think for UK, by the time the clock will turn around, so it'll be 5 p.m. for us. That will be excellent. Thank you if you let me know in time. So I will put out the ad for the next one on 21st of June. Thank you so much.
Dr. Shobi, the 1 hour discussion with a single, residence talk will be probably too much. I think you can divide it. Small talk with the trainee presenter and a faculty.
Absolutely. We can do it either way. We can do it. Yeah, as long as I know what the topic is, it'll be easy that we can divide it. We can have 2 speakers, no problem. No problem. It's good for discussion. It's a good for discussion, but it gives perspective to the trainees as well to face an August gathering, isn't it? I think it'll be very good. And Fazol, please, you can help me as well. In NIPDO, I'm sure.
Definitely.
Thank you so much.
Professor Prabhat, is the 21st of June will not be collide with the upcoming BAUS meeting or not? Can see.
Please have a look. Yeah, please
sure,
have a look.
Sure. Before that, there will be BAUS meeting. Then I can convey the message to all of
yes.
the.
Thank you so much. Yeah. And I'll pass on to Kausar. You're the moderator. I don't want to steal the program. To close, bring a closure. Yeah.
Yeah. We are okay. We are just over 1 hour. I mean, there's one more question here. Shall we take it or shall we conclude?
I think.
No, take it. No issue.
I think someone asked about was it Dr. Mr. Siddiq? Is how do you mitigate the drawbacks of minimal invasive operations, because they are laparoscopic or robotic? They will have pneumoperitoneum, they will have certain position of the table, so they get some stressful situation on the heart and lung because of this positioning. How do you mitigate this? I think the Fazul Bhai has good experience of minimally invasive operation. Do you want to take the question, Fazul Bhai?
Well, in case of laparoscopy, this steep tender position is maintained up to the cystectomy and the lymph node dissection. After that, we neutralize the table, so it doesn't make any difference. Okay.
Yeah, and because
it is only for half an hour or something like that.
Yeah. It's around 1.5 hours.
Okay. So I think thank you so much for the kind contribution. We are very happy and delighted and lucky that we had a very resourceful panel today. And thank you so much for all these experienced professors and surgeons from Bangladesh and to join us, and then we benefited each other. We are looking forward to attend the next meeting. So Shafi Bhai, do you want to say the closing?
Yeah. So inshallah, see you all 21st of June. Hopefully we'll get some information on the volunteers who's going to be presenting, and also from faculty point of view as well. If we have a faculty meeting, I'll confirm nearer to the time and the topic as well. So it'll be, I'm sure it'll be an excellent conversation at that time. Thank you all, and assalamu alaikum from my side.
Assalamu alaikum.
Okay.
Thank you so much.
Assalamu alaikum.
Thank you so much. Great.
Assalamu alaikum, sir.
Ji, wa alaikum assalam. Bhalo থাকুন সবাই. Good night.